So I wanted to start by acknowledging that a lot of us have struggled over the last year, and this pandemic not only has brought a lot of pre-existing issues to the surface, but also caused a whole new range of difficulties. And as a psychotherapist, I've been observing my own process and reactions to this pandemic. And I've also seen a lot of my colleagues and friends wrestling with homeworking, loneliness, sense of overwhelm, and sometimes even with bereavement, depression, anxiety, and trauma. My name is Karol Kuczera. I work for NHS England and NHS Improvement in the Southeast region, and I'm joined here today by Dr. Chris Rivers to talk about mental health and disability. So without further ado, Chris, if you could introduce yourself and tell us a little bit about what attracted you to work in this area.
So hi, yes, I'm Christian Rivers. I lead on the Workforce Disability Equality Standard. And what attracted to me this area, I've worked in disability for 3 years, leading on the WDES. And before that, I was an EDI lead. I did a PhD in sociology, social theory, particularly looking at sexual orientation and mental health and the connections between those. When I was an EDI lead, I co-led and set up a lived experience network for people with lived experience of mental ill health. So I gained a lot of experience and knowledge from co-leading that work, and particularly insight into the experiences of people with lived experience of mental ill health through that group.
I guess, I don't know if you would like to share something about this in this space, but would you like to say something about your own experiences of mental health?
So I think mental ill health is often hidden, and I think it's something that it's really important that we all talk about more, and as leaders we talk about more. So my own experience, I had burnout, which prevented me from working for about 3 months, which severely affected my mental health. But my wife has a long-term mental health condition, has used mental health services, was using them when I worked in a trust, and that presented conflicts and challenges for me as an employee. So there's been a very personal relationship for me with mental ill health through my own experiences and those of my wife.
Yeah, thank you for sharing that, because I guess some people still may be very hesitant to talk about mental health. And so what barriers do you think prevent them from doing this?
I think there are a lot of barriers around stigma, particularly, and because mental ill health is a hidden disability, then a lot of people can assume that you haven't got a mental health condition. You have to say that you do, and once you do, there's the potential of people's prejudice about mental ill health, particularly when someone works in a mental health trust, for example. Colleagues are talking about service users and people with lived experience all the time, and sometimes that's not in as much a respectful way as it could be. So there's some challenges around that. I think it's really important that people feel safe. Disabilities, hidden disabilities, don't need to be hidden. In a workplace culture, if we can get that right, people will feel comfortable to say they have a mental health condition or other disabilities, invisible or visible. And I guess the important thing is to create safe spaces, so things like networks, supportive colleagues. Again, when I was leading on a lived experience network, quite a lot of people came and talked to me that I'd worked with for a long time and said they had lived experience of mental ill health, and that was because it was a safe space and it was someone where people felt they wouldn't be judged. It's important that we have as many spaces as we can in the NHS for people to speak.
And I guess it's really important to kind of expand a little bit on what you're saying, because how do we create those psychologically safe spaces for different groups? Research tells us that people from underrepresented groups such as BAME or LGBTQ+ may experience higher rates of mental health difficulties than the general population. So why, in your opinion, do you think this is the case?
So I think it's the impact of double stigma. I think if you're experiencing racism as a BAME person, or homophobia or transphobia already, and then that can impact on your mental health. and people may either experience stress as a result of that, or for some people that can lead into mental health conditions. And I suppose there's a couple of things I would say. I think it's really important to bring in the benefits of people with lived experience, disabled people, and that's really important because we're a healthcare provider. 70% of the people using our services have a disability, or at that point, maybe if you've broken your leg, you don't have a long-term disability, but you are experiencing some of the difficulties, for example, in access that disabled people would experience. So for us as a healthcare organisation, it's really important that we listen to the experiences of people with lived experience of mental health, and particularly as well people who are also BAME, that intersectional people who are also LGBT, and their own experiences that are part of mental health being part of those people's experience through stress or through racism. And the way forwards is an inclusive culture. So it sounds simple, it's harder to create, but this is about talking about disability, talking about lived experience of mental health, talking about the impact of homophobia and seeking to address it, creating spaces, as we've just said, safe spaces where people can feel comfortable to talk about who they are, so that people don't have to hide a big part of who they are through a hidden disability, or for example, through being trans or being LGBT.
And I guess that leads on to thinking about how those disabilities may be seen in the workplace. So representation does matter, right? So when we know that being able to see ourselves represented and our leaders is really important, especially in the workplace, I think. So can you say a bit more about this, given that you are also a very important leader in this space?
So we know from the WDES data that the more senior you are, the less likely you are to say that you have a disability. On ESR across the board, about 3.5% of people say they have a disability, and that contrasts with about 19% on the NHS staff survey, which is anonymous. So what we know is around 20% of the workforce say they have a disability, but that isn't reflected on the ESR. So there's quite a lot of work on disability and leadership, particularly where we need to talk with disabled leaders and particularly think about career development of disabled staff as well, because sometimes when people are flexible working or have reasonable adjustments, people feel they're less likely to be considered for promotion, and we need to change the culture, increase people's awareness of leaders who do have disabilities and manage their work fine and have reasonable adjustments in place, and that's no issue. And in the end, you know, the NHS has 1.3 million staff. It's the second biggest employer in Europe. We can make a difference. We can make a difference for our workforce, and we can also make a difference within our culture, because we've got so many staff. We've got a significant number of people who can go out into the community and influence others.
Indeed, and I guess this may be a little bit of a challenging question, but linking up to the ESR, which is the electronic staff record, you know, why should people declare their information about their disability on ESR?
So I think that's an important question, because if you say you have a disability on ESR, it doesn't automatically go to your line manager. So you need to still have a conversation with your line manager. They won't know, because it's protected confidential information. But there's a key thing here about visibility, and for managers and for policymakers and for people looking at the data, if we're looking at 3.5%, when that's not a very big percentage. So although we can understand to some degree the experience of disabled people through that 3.5%, and we can understand where people are within the hierarchy, let's say the hierarchy, the pay bands of the NHS, we can't really understand people's experiences properly unless we have good data. So I think on a trust level, so the trust knows how many disabled people it has within its organisation, it will take more notice if that number is bigger. On a regional level as well, once you start to move up, then that impacts on your understanding of people within the organisation. And then nationally as well, we can create national findings from the data that we have. So the better data we have, the more loudly we can speak and the more we can say about disabled people's experiences.
Yes, and I guess there's also something about not only how we can then wrap certain services around this, but also thinking about reasonable adjustments too. So this was a topic that came up recently. So, you know, as a senior leader, do you think that major organizations like, for instance, the NHS should kind of mainstream reasonable adjustments to encourage more disabled people to join the workforce and to reduce capability hearings?
So I think by that you mean mainstream budgets for
Indeed, yes.
reasonable adjustments. So absolutely, I think that, again, in my experience in a trust, local managers have smaller budgets. And what it means is that managers worry about the money they're spending. And if you're looking at something like access to work, you spend out and then you can't claim back. And if you've only got a small budget, that's a difficult decision for a manager. And of course it shouldn't, but of course it impacts on some people's perception of disabled staff. So not all adjustments cost money, but for some people they do. And it's really important that an organisation takes away that sort of financial impact for a local manager or a local team. And sometimes in some of the cases where I was working, if it went over a financial year, that was a problem as well, because trusts work financial year to financial year. So the reason to have centralised budgets, and I've got a figure, it's only 13% of trusts that actually have centralised budgets. So we know that centralised budgets for reasonable adjustments works much better. It means that managers can think about those adjustments, not be concerned about the money coming back in the next financial year, and put that in place much easier. So that's the way to do it. And yes, one of the areas that we're working at on as the WDES team is to increase the number of trusts with centralised budgets for adjustments. So access to work, you can claim the money back. So and the key thing to say is not all adjustments cost money. It's things like flexible working, things like additional support doesn't cost anything, buddying, additional coaching sometimes within the organisation. These don't cost money, but nevertheless, where money is involved, it's really important to have a good system in place.
Chris, we know that this pandemic unfortunately has shown a lot of light on pre-existing health inequalities. So can you talk a little bit about the impact on mental health because of, say, you know, some people who were shielding?
So absolutely. So I think people who are shielding will be shielding because of physical health conditions, but nevertheless, shielding can have quite an impact. We did a survey on disabled staff in COVID, and most people said that there was an impact from shielding on people's mental health. And there are some positives. For example, people aren't having to travel into work or commute every day. People have got potentially more space within an environment that feels comfortable. But there's also challenges from isolation and loneliness, and longer hours for many people, because it's sometimes easier to or harder to have a work-life balance, easier to stay at work when you're working from home. So for all of those reasons, there's an impact. For when we asked people about the impact, most people said it was negative rather than positive. So I think it's really important. There's a kind of a need to rethink some of the ways we work. And within that, I think it's really important that colleagues and line managers think about people's needs. And the main thing would be to talk to people. There's health and wellbeing conversations about what people need, and it doesn't have to. The system is the health and wellbeing conversation, but the main thing is for a line manager to sit down and talk with a person and find out what they feel they need, any challenges that they're facing, whether they want to come to work. For example, there's people who have been in domestic violence situations that need to get away and need a workspace where they're not at home with somebody who's being abusive during their work time. So it's really important that we have those spaces where people can be at work when they need to be.
We are now seeing an increased level of trauma and post-traumatic stress in the NHS workforce, and some research was suggesting between 22 to 40% of healthcare professionals being affected by this. So is this new, and do we need to start thinking about this differently?
So I would say it's not new. I would say there's been many people with lived experience of mental ill health working in our services for many years. But what maybe there's two things that are new. One is a new way of working from COVID, with more people potentially living and working from home, and more people impacted by the fact that we're a healthcare services delivering healthcare in a pandemic, and that has impacted on many people's mental health, whether they are people who had prior existing conditions or not. So we're also having to think about some people who are new to lived experience of mental health, for example, who wouldn't have had mental health conditions before, or people who have mental health conditions who have been made worse by the pandemic. So there is quite a lot of thinking around that, and a lot of recognition. There's quite a lot of money going into considering mental health for the workforce. There's going to be mental health hubs, but also many trusts have employee assistance programs, mental health first aiders, lived experience networks for staff with lived experience of mental ill health. So there are things around for people, and there's more thinking about what that can be.
Great. And I guess, also thinking to that is that we know that in general population, 1 in 4 people are affected by mental health conditions. How is disability protected under the law?
Okay, so the Equality Act says that you are protected if you have a condition that has a substantial impact on your ability to carry out your day-to-day activities. So it needs to be substantial and long-term. So substantial is that it affects you every day. Long-term is that it needs to last or be expected to last for at least 6 months. So if you had something like depression, you wouldn't have to wait 6 months. It would protect you because that condition would be expected to last 6 months or more. There's 3 conditions that are automatically always included, and those are HIV, cancer, and multiple sclerosis. So when the Equality Act was created 10 years ago, it set out those conditions. So it doesn't matter what the impact, because most of the Equality Act sets out the protection by its impact. But for these 3 conditions, HIV, cancer, and MS, it doesn't matter. If you have that diagnosis, you are covered by the Act.
Okay, so Chris, before we finish, and thank you so much for this conversation today, I guess I would like to know if you have any tips or ideas about how managers can talk to staff about mental health, and where can staff access support?
So I think it's always the golden rule is to ask the person. So I think there's a couple of things. So I think, especially with something like mental ill health, I think it's giving people permission to talk. So I would like managers to talk about mental health in general, talk positively about mental health, talk about the benefits that people with lived experience bring to the workplace, and that signals a safe space. And that's for leaders as well, to be talking about mental ill health or talk about their own experience if they feel comfortable to do that, because that also creates safe spaces for people to feel more confident. And the more people that feel confident and talk about lived experience of mental ill health, the more that can create safe space for others. I think the other thing is to have champions, to have a network, to have a specific network for people with lived experience of mental ill health. That certainly can really be beneficial, and for, I guess, to have people that people can talk to, identified people that are available on the intranet, or in information where people can know that they will have a private, safe, confidential space where they can talk about what's happening to them.
Fantastic, great. Thank you so much, Chris. I mean, this has been certainly an enlightening conversation for me. So we will post this video on the Leadership Academy website, and thank you so much for your time today.
Thank you.